Hey everyone, I want to tell you about a case that I recently had. It was a case where a patient came in with shortness of breath, and of course I did a lung ultrasound, and it had a little bit of a unique finding and really went to show that knowing patterns and pattern recognition, both clinically and in ultrasound, really make a difference in clinical care. And really, the more you do, the more you recognize it. So this was a 55-year-old lady. She presented with a few days of acute shortness of breath. She presented to the emergency department. She had no chest pain. She had no leg swelling. As far as I knew, she had a history of COPD. And when she arrived at the emergency department, she was brought back to our resuscitation bay because she was tachypnic in the 40s, and her oxygen saturation was reportedly in the 60s in triage. When we put her on the oxygen saturation monitor, she had an O2 sat of 55%. She was a little bit tachypnic, was able to speak, and looked fairly comfortable for someone with an oxygen saturation of 55%. So what I was thinking was probably what a lot of you are thinking who were working during COVID, is that this looked like the happy hypoxia from COVID. And my first fear was like, oh my God, is COVID the original COVID back? So yeah, that certainly took me by surprise. We placed her on a non-rebreather mask, and her oxygen slowly started to come up into the 70s and ended up switching her over to BiPAP. So of course we listened to her lungs, and her lungs were actually relatively clear, which was a little bit surprising for that oxygen saturation. But I know how limited physical exam is, so of course I took out the ultrasound to really take a look at her lungs and see what's going on. So when I first looked at this lung ultrasound, the first thing that struck me was, look how many B lines there are. It almost looks like there's one giant coalesced B line throughout that entire lung. It would be very atypical for what I typically see in pulmonary edema, where I see very distinct B lines. Some of them might coalesce, but I at least can somewhat count the number of B lines. Here it became impossible. I almost see a few distinct B lines coming through here on the sides, but nothing that I would say, hey, this actually looks like a normal pulmonary edema pattern to me, and this is actually what I saw in most of the lung. So when I'm seeing something like that, and this patient is not fitting the pulmonary edema picture, typically patients coming in with acute CHF are in much more respiratory distress. She was more of like kind of the happy hypoxia. So next thing I do is I say, okay, this isn't quite normal. Let me look up here at the pleura, and the looks a little bit jagged. Normally with pulmonary edema, the pleura should look perfectly smooth, but here there's a little bit of jagged to it. It wasn't a super shred like a pneumonia, but it was certainly a little bit abnormal. Here's a lateral view at the base. There was a trace pleural effusion over here, but otherwise the parenchyma just looks like that B lines and looks pretty much the same. So this is very curious because the patient didn't look like normally pulmonary edema. The B lines look pretty distinct, and so it's important then to remember at this point that there is actually a differential for B lines. And so we're often taught that diffuse B lines means pulmonary edema, but there can be other causes of B lines. When I'm seeing abnormal B lines, when I'm seeing diffuse B lines, and especially with an abnormal looking pleura, but especially in a patient who doesn't fit properly, you got to think about that differential. And what that differential includes is interstitial lung disease, which can give you similar B lines. Usually those B lines are relatively normal, meaning that they look more like pulmonary edema, but sometimes not. And especially having seen pulmonary edema 1,000 times and knowing what that B line pattern looks like, this really didn't fit the pattern. Again, going to other parts of the lung, this certainly didn't seem like normal pulmonary edema pattern that I'm used to seeing. The other thing that's in the differential is certainly viral. Viral can give you a little bit of shred of the pleura, and COVID actually looked like this with what was described as a waterfall appearance of the lungs. So interstitial lung disease and viral infections were certainly in the differential. Now, she had very difficult cardiac views, and the only decent one I got was an apical 4-chamber view. Looking at the left ventricle, an apical 4 isn't the best to look for qualitative assessment of ejection fraction, but you can see this actually looks pretty good. The walls are squeezing pretty well. She certainly has no significant CHF. But if you look at the right side, she's got a big right ventricle. The free wall, for what you can see, it looks pretty normal. But my feeling was that this was probably chronic, and the reason is if you look up here above the moderator band, it looks decently thick, which suggests something chronic, and certainly with her history of COPD, which was the only thing I knew at the time, that would correlate with that. So all this is to say, not all diffuse B lines are pulmonary edema, and it's important to take the clinical context, your echo, and some of the other subtle findings. She Ended up getting a CT. It turned out it was bronchiectasis that was not known before and had a lot of interstitial lung changes versus viral also, which can give you sort of that similar kind of diffuse B-line lung diseases like COVID, although her COVID ended up being negative. So don't have to worry about the original COVID coming back, at least for now. I hope you enjoyed and you learned something, and I'll see you on the next one.